So after the completion of the previous lecture of hypertensive crisis, now I'm going to tell you something about the acute kidney injury. What do you mean by acute kidney injury? So, by the description, acute kidney injury is the rapid loss of kidney functions from renal cell damage, occurs abruptly and can be reversible. And AKI also leads to hypoperfusion, cell death, and decompensation of the renal function. The prognosis depends on the cause and the condition of the client. Near normal or the normal kidney functions may resume gradually. So, by the definition, it is clearly mentioned that the rapid loss of kidney function from the renal cell damage is the main causative factor for acute kidney injury. Second thing is acute renal failure occurs suddenly as a result of physical injury, infection, inflammation, or damage from the toxic chemicals. Nephrotic agents are those that are poisonous to kidney cells and include many drugs like iodine substances used as the radiographic contrast media, heavy metals, snake venom or exposed to industrial chemicals. और बार हम लोग को ये देखने में आता है कि जैसे कि रेडियोग्राफिक कॉन्ट्रास्ट अगर डाई यूज़ करते हैं कुछ इमेजिंग टेक इमेज लेने के लिए लाइक at the time many times we are sending the level of creatinine because if the creatinine level is high at that time it will again increase the toxicity like the snake venoms or exposed to the heavy chemicals are also big causes for acute tubal injury. Those toxins may inflict the damage of the tubal functions causing acute necrosis and loss of functions. They can also indirectly harm the tubules by causing severe constriction of the blood vessels that serve the kidney and producing the renal ischemia. 18 is responsible for 90% cases of the acute renal failure. So it is very much clear that acute tuberculosis is the most commonest factor of the acute kidney injury. Other causes of renal ischemia like circulatory collapse, severe dehydration or prolonged hypotension in compromised surgical or the trauma patients. These are also the major causes, other causes like circulatory collapse and severe dehydration. This is the prerenal causes of acute kidney injury like prerenal outside the kidney by the name it is clearly you can think about that when this is caused by the intravascular volume depletion such as with blood loss associated with the trauma or surgery means like dehydration, decreased cardiac output, decreased peripheral resistance, decreased resistance to the blood flow, prerenal or infection or obstruction. Internal causes like within the pericardium of the kidney occurs from the glomerular damage, acute tuberous necrosis, prolonged prerenal ischemia, internal infection or obstruction, and the nephrotoxicity. Post-renal causes such as between the kidney and the urethral matters like bladder neck obstruction, bladder cancer, calculi, and the post-renal infections. So ARF is potentially reversible, especially it identified early the patients when they regain the kidney functions. So many times we are seeing in our clinical practice that if a patient comes to you with severe vomiting or loose motions at the time, it is must for us to ask them about the renal output because many times it happens that the renal shutdown is there just because of the renal factors and which lead to dehydration and the kidney shutdown is there. So acute renal failure can easily see here that the prerenal causes, intrarenal causes, and the postrenal causes. These are the three major things in which we are we see the patients of the acute kidney injury. Prerenal causes like shock, CHF, sepsis, anaphylaxis, pulmonary embolism, cardiac tamponade, and the renal artery stenosis, due to which there is a decreased blood flow and decreased oxygen may lead to the tissue damages, which leads to the decreased glomerular filtration rate, decreased tubular functions, lead to decreased hormone secretion, and decreased ability to excrete the fluid, hydrogen ions, potassium ions, sodium ions, nitrogen wastes, and as phosphates. So these are the pre-renal causes which may lead to tissue damage. Then there are enteral causes like nephritis, nephrotoxins, acute glomerulonephritis, vasculitis, acute tubular necrosis, and hepatorenal syndrome, which leads to tissue damage, which leads to decreased glomerular filtration rate, decreased tubular functions, decreased hormone secretion. Then the rest is the same thing, that decreased ability to excrete the fluid, hydrogen, potassium, and sodium, like sodium. The renal causes include urethral obstruction, bladder injury, prostatic hyperplasia, urethral strictures, and the cervical cancers, which leads to obstruction and the blockage of the urine with increased pressure. So, and the rest is the same thing, like tissue damage, decreased glomerular filtration rate, tubular function decreased, hormone secretion also decreased, which may lead to decrease the ability of the kidney functions. Chronic renal failure and disseminated reserve renal insufficiency and stage renal threat disease, we see that the fluid overload may lead to ischemia, edema, and the congestive cardiac failure, metabolic acidosis, hypernatremia, sodium, uh, sodium imbalance, and anemia and obstructive. So after this phases of ECA is onset begins with the precipitating event, oliguric phase for some in which oliguric phase for some clients oliguria does not occur and the unit is normal. Otherwise, the duration of oliguria is 8 to 15 days. The longer the duration, the less chances of recovery, which is oliguric phase. Because the मतलब oliguria is 8 to 15 days का duration हो जाता है. The patient is not maintaining the urine output at that time. This is very less chance of recovery is there, and the less chance of reversible kidney. Sudden decrease in the cardiac output, urine output is less than 400 ml per day. Signs of excess fluid volume like hypertension, edema, fluid in the pericardial effusions, dysarrhythmia, heart failure, and the pulmonary edema. Signs of uremia क्या मिलता है आपको? Anorexia, nausea, vomiting, pruritus like signs. Signs of metabolic acidosis, in which we are getting the respiration is disturbed and it is like a small respirations. So in case onset begins with the precipitating agent, on the oliguric phase you may easily it is clear to you that what are the clinical findings of the patient, what are the signs of the patients like anorexia, nausea, vomiting, pruritus, small respiration, and what are the phases of AKI. Signs of neurological changes like tingling of extremities, drowsiness, progression to disorientation, and then coma. So these are the signs of neurological changes when we see that if the patient comes to you with in case his or his creatinine is too much high at the time, if we are getting the signs of neurological changes like tingling of the extremities and drowsiness, which may lead to the coma. So we should be very much cautious regarding the AKI patients. What are the signs of pericarditis like friction rub, chest pain with inspiration, and low-grade fever? We may get all the signs of pericarditis as well. In this sense of uremic syndrome, first step in the life-threatening conditions such as hypokalemia develop. That's why we are very much cautious. हम लोग ध्यान रखते हैं कि पेशेंट का कार्डियक आउटपुट मेंटेन है कि नहीं. क्रिएटिनिन अगर उसका गड़बड़ है और आपने उसमें पोटेशियम है और अगर आपने उसके अंदर ऐसा फ्लूइड दे दिया जिसमें पोटेशियम जैसा लिंगल एक्टेड है, अगर आपने उसका ध्यान नहीं रखा और कार्डियक आउटपुट मेंटेन नहीं किया तो उससे अननेसेसरी अरिथमियाज के चांसेस बन जाते हैं और इट में लीड टू डेथ एज वेल. सो जब भी आप पेशेंट देखेंगे तो यू मस्ट सी इन द साइंस ऑफ पेरिकार्डाइटिस इन विच देयर इज चेस्ट पेन विथ लो ग्रेड फीवर and neurological changes like tingling of extremities, which may lead to coma as well. Intervention with early recognition of potential for AKI, client may be treated with fluid challenges like IV bolus of 500 to 1000 ml or 1 hour. So, how do you treat the patient? By restricted fluid intake. If hypertension is present, daily fluid allowance may be 400 to 1000 ml plus the measured urinary output. Administer the medications such as diuretics it's prescribed to increase the renal blood flow and the diuresis drain the fluid and the electrolytes. So what are the interventions? You have to give the food challenge therapy in which you have to give IV bolus to 5,000 sorry 500 to 1,000 ml for only for 1 hour. Okay, so in case diuretic phase, you do not put rises slowly, followed by the diuresis, 4 to 5 liter per day. In diuretic phase, we are seeing 4 to 5 liters per day. Second thing is that excessive output indicates that damaged nephrons are recovering their ability to exceed the waste. This is the recovery phase. Third, then another thing is dehydration, hypovolemia, hypotension, tachycardia can occur. Level of consciousness is improved. This we are getting in the diuretic phase, means rises slowly of urine output more than 4 to 5 liter per day, and the level of consciousness will also improve, and dehydration, and consciousness will improve. Intervention, laboratory analysis, administer means after diabetic phase and because intervention laboratory analysis, we should go for the laboratory analysis. Administer IV fluids as prescribed, which may contain electrolyte to replace the losses. In case recovery phase, recovery is a slow process. Complete recovery may take 1 to 2 years. Volume returns to the normal level. Memory is also improved, and the older adults is less likely to younger adult to regain the full kidney functions. Means the younger patient, the chances of improvement is better in case young patients. और कैसे देखेंगे आपकी मेमोरी इंप्रूव हो रही है, यूरिन आउटपुट उसका नॉर्मल मेंटेन कर रहा है. लगभग इस फेज़ को बहुत बार 1 से 2 साल भी हो सकते हैं रिकवरी फेज़ के लिए. In case these interventions, laboratory analysis and AKI can progress to CKD. Diagnosis. So in case diagnosis, BUN increase depends on the degree of catabolism, protein breakdown, renal perfusion, and protein intake. Serum creatinine levels will be high. Radiological studies like such as ultrasound, CT or MRI should evidence for the anatomical changes like the renal pericardial disease. जब ये ऐसा कोई पेशेंट आता है जिसके अंदर एक्यूट इंजरी और सीकेडी में थोड़ा सा अंतर करना होता है, तो मोस्ट ऑफ द टाइम वी सी दैट देयर इज एनी contracted kidney or the small or the contracted kidneys and the creatinine level is high, then we see think about and the other parameters as well. We think about the chronic kidney disease which is not reversible. A renal biopsy may be obtained to assist in determining the cause of to evaluate the extent of kidney injury. CBC like anemia can occur as a result of reduced erythropoietin production and reduced lifespan of RBCs. Prevention. How will you prevent so sorry for the interruption. So अब आपको पता चल गया कि हाउ डू यू डायग्नोज केस ऑफ CKD or level of AKI. AKI is reversible and chronic kidney disease is not reversible. So we should be very much cautious regarding the conditions of acute kidney injury like renal, internal, postrenal causes. So as you see that USG may also is very much beneficial. So evidence of anatomical changes in case blood creatinine levels are high, and in case CBC examinations, anemia or reduced erythropoietin production, reduce their RBC lifespan. Prevention. Continuously assess the renal functions like kidney output, urine output, laboratory values when appropriate. Monitor the central venous pressure and the arterial pressure and hourly urine output in the case of critically ill patients. You should monitor the central venous and the arterial pressure. So रेनल फंक्शन को असेस करने के लिए आप यूरिन आउटपुट देखते हैं, लेबोरेटरी वैल्यूज़ के ऊपर आप को कोरिलेट करते हैं, देन यू थिंक अबाउट द ये क्या है. प्रिवेंशन एंड ट्रीट द शॉक प्रॉम्प्टली, द ब्लड एंड द फ्लूइड रिप्लेसमेंट शुड बी देयर. So prevention मतलब prevent करना आपको easily early treatment of the shock will definitely improve the condition of the patients. Prevention of the treat infections promptly. Infection produces the progressive kidney injury. Because अगर आपको शायद पता चलता है कि this tubular stenosis is just because of the um, some kind of infections and can produce the progressive kidney damage, so you should treat it properly. How do you prevent prevention for the avoid severe transfusion reactions, prevent ascending urinary tract infections, to maintain toxic drug effects, dosage duration, the blood vessels also to the metabolic medications metabolized or excreted by the kidney. Treat hypertension promptly. What about the medical management? It is very much important for a clinician to treat such kind of cases very promptly to reduce the further damage, because ATN may lead to a CKD and which is not reversible, and the only option for that is like dialysis sort of thing. I am going to tell you later about this treatment. So what about the medical management? Treatment of ARF is aimed towards correcting the underlying causes and preventing or controlling complications and maintain a tolerant internal environment until the kidneys are able to recover and resume their normal functions. So, important thing is the most important thing is the treatment of the underlying causes and preventing or controlling the complications, so that we should reverse the effects of the damage to the kidney. Symptomatic treatment includes correction of the fluid and electrolyte balance, management of anemia and hypertension, and cleansing the blood and tissues of waste products with hemodialysis, like filtration of the blood across the seminous membrane, or peritonitis, in which filtration of blood across the peritoneal membrane. So, symptomatic treatment is must for you to maintain the correction of electrolyte balance and management of hypertension and anemia. And one thing is, if the kidney is not maintained to the proper kidney output and there are collection of waste products, in that cases we should go for the hemodialysis. And hemodialysis or peritonitis. What about the pharmacological therapy? IV extra 50% insulin and calcium replaced may be administered to shift the potassium back into cells. Diuretic agents are often administered to control the fluid volume. What about the medical management? Volume overload is treated with diuretics and some of the low rise dopamine to promote the better kidney perfusion. So this is this was the controversial thing that the dopamine of the dose, what should be used the dopamine dose, and we can think that central low dose dopamine will improve the renal functions. It is the renal dose of dopamine in such cases. Second thing is dialysis is also used to reduce volume overload. It cannot be reduced with drugs. Electrolyte imbalance like hyperkalemia, hypocalcemia, hypophosphatemia with mild hypoglycemia are monitored and treated. Metabolic acidosis, if severe, is treated with IV sodium bicarbonate. A replacement of dietary proteins is individualized to provide the maximum benefit and minimize uremic symptoms, likewise caloric requirements are met with non-carbohydrate meals because when the potassium or the phosphorus are restricted, and after the diuretic phase the patient is placed on a high protein high calorie diet. Earlier because like the patient history including questions that relate to fluid imbalance and the potential risk factors. Fluid imbalance is that changes in the voiding patterns, fat gain, muscle cramps, cardiac arrhythmia or palpitations, vomiting or edema. Potential risk factors such that patients or the family history of the renal disease or hypertension, recent surgeries or trauma or anesthesia, and exposure of the nephrotic substance or any kind of medications. Laboratory investigations, we can assess by the laboratory investigations like increase in the creatinine level and anemia. So for the diagnosis, fluid volume excess due to decreased kidney functions, altered nutrition due to nausea and loss of appetite, altered activity tolerance due to metabolic changes, potential for the infection due to enabling urinary catheter. Okay, so nursing intervention is also very much important, in which we have monitor vital signs, especially for the signs of hypertension, tachycardia, tachypnea, and irregular heart rate. Monitor daily weight, in which the same skills, same clothes, same the time of the day. Nothing that an increase of 0.5 to 1 will be per day, 0.25 to more, 0.5 kg per day indicates fluid retention. Monitor for the changes in the bune, serum creatinine, and the serum electrolytes levels. Monitor for the acidosis, may need to be treated with sodium bicarbonate. Sometimes the dyspnea is because of this acidosis, and the early correction for the acidosis by the bicarbonate is very much helpful for the patients. Monitor urine analysis for protein level, hematuria, casts, and specific gravity. Monitor for the altered level of consciousness caused by the uremia. Monitor for the signs of infection because the client may not exhibit an elevated temperature or the increased WC count. Monitor the lungs for the V's and bronchi and the monitor for the edema, which can indicate fluid overload. How will you monitor edema? By seeing in the above the level limbs. If there is pitting edema at the time, you can easily that this edema is just because of volume overload. And in lungs, you see the patient's complaining of dyspnea at the time when you are going to auscultate that patient, you may get the V's and the bronchi. Administer the prescribed diet, which is usually a low, moderate protein to decrease the workload of the kidneys, and high carbohydrate in the ill clients may require the nutritional support with the supplements, until feedings or the parental nutrition. Restricted potassium or the sodium intake is prescribed based on the electrolyte level. The administer the medications as prescribed. Be alert on the mechanism for the metabolism of the execution of the prescribed medications. Be alert to the nephrotoxic medications which may be prescribed. Prepare the client for the dialysis if required. Prescribed continuous renal replacement therapy may be used in AKI to treat the fluid overload or metabolic acidosis. Provide emotional support by allowing the opportunities for the client to express the concerns and the fear by encouraging the family interaction. So, what are the nursing investigations you may easily is that monitor the vital signs and correlate it with the clinical signs of a patient of acute kidney necrosis, as well as it is important for us that early initial diagnosis of the CKD is very much important, and we should be very much cautious while treating the patients, because the early and the prompt treatment of the patients of acute kidney injury may help to the patients on a very lot of the basis, and for the diagnosis you can easily diagnose the case of acute kidney injury, and the prompt treatment is given according to the creatinine level, and in which the initial measures you may also go for the dialysis like peritoneal dialysis and hemodialysis, which may lead to further irreversible irreversible causes of the kidney injury. So according to these things you can easily, the next report I will show you after this lecture. So the important thing is that अगर a patient आपके पास में आता है and it comes with the, so you have to find out that this is the cause of acute kidney disease because of acute kidney injury or chronic kidney injury. For the acute kidney injuries, I'm not going to detail, but I'm going to teach you something in the short that if first we should realize that what is the cause of that raised in the creatinine level. So at that time we can send the patient for the blood investigation as well as for the USG findings of the kidney, because if there is the increase in the level of creatinine and decreased urine output, so you think about the tubular injury and prompt treatment is required. Second thing is that many times the patient is not ready for such kind of treatment. At that time you have to carefully watch regarding the injuries to the patient. And what are the other management acute necrosis? So this is mainly that improve the renal functions, because acute pneumonia is diagnosed by the reduced uh, cardiac output, urine output. So just you have to maintain the, you have to give the fluid challenge to the patients and avoid the nephrotoxic agents which we are using, and you have to avoid further like iodine, which are used as a dye in the clinical imaging techniques, and the nephrotoxic agents. And if you are going to treat the infections, so you have to treat on a very tighter dose of many antibiotics like piperacillin tazobactam if you are using, or you are using meropenem or the higher antibiotics. So you should be very much cautious regarding, and you have to maintain the cardiac output. If you are not maintaining the cardiac output, then such please avoid the conditions which may lead to hyperkalemia, and the drugs which may lead to like ACE inhibitors, like ramipril. Okay, and second thing is like potassium spring diuretics like aldactone. You should be very much cautious regarding those products when you are using that. So the key points for this acute pulmonary injury for the diagnosis and the treatment is that you first diagnose the patient if there is increased creatinine levels and decreased urine output, and you just correct the conditions like dehydration and the volume loss. You have to give the fluid challenge therapy, which is important for the patient, and it may improve the clinical output of the patient, and which may lead to reverse the condition, which may lead to further chronic kidney disease. So after this topic, I think that आप लोग समझ होंगे इसको कि what is acute kidney injury. So बस last point ये है कि how you going to differentiate between acute kidney injury and chronic kidney injury. So on the imaging techniques, you are just see the ultrasound of the patients, and if you got contracted small contracted kidneys. So, and in case acute pneumonia, you are not getting any kind of renal pain abnormal. Mostly mild changes, maybe they're just because of some faults. Clinical error may be there, but this is the most different points by which you can diagnose that this is the case of acute kidney injury or the chronic kidney injury. Okay, so after this topic, we will also cover the topic about chronic kidney disease. So just okay, thank you.